first about the causes of fluid overload in dialysis patient. First one is that every time when we take dialysis, patients comes with 5 kg or 6 kg weight gain, we feel irritated. How to take care of this patient? He may go for hypotension in 4-hour dialysis session. We cannot treat the patient that much easily with 4-hour dialysis session. We have to do something to avoid complication at the end of the dialysis. So in our center, we have been educating the patient by showing some videographs and giving some brochures and oral presentation how you can prevent the water decrease your water intake by decreasing your salt intake. All those things we have done. But still, patients takes too much water and comes with too much weight gain, giving us a big trouble in treating them without any complication. So, patient usually feels tired and will not be able to work in first 6. That is after dialysis, they will feel at least 6 hours after dialysis. They will feel uncomfortable and tired after dialysis. But when they face complication, it becomes like at least 12 to 24 hours for the patient to come back to the normal state. So how we can prevent this kind of complication is what we are going to discuss mainly in this presentation. Before that, we are going to discuss about the use of dialysis. What is the reason why we have to use a dialysis? Why we should not use water, just water to clean the blood, treated water. It also can remove the uremic wastes. But what it does is that it can remove uremic waste along with all the electrolytes and essential products from the blood as well. That is why we use composition patented by Ito Nobuo of Nikiso, Japan in 1990. The dialysis which we are using now is a composition of 1 ratio of acid concentrate, that is part A, and 1.83 ratio of bicarb and 34 parts of water. This is the normal composition of the dialysis which is present in our dialysis which we are using. And acetate dialysis is not used nowadays much. We are going to discuss why it is not used much nowadays. And the bicarb dialysis, citrate dialysis is also now used widely. So almost all of these compositions are same in all the 3 dialysis except the acetate, citrate and bicarbonate. Next we are going to discuss about advantages and disadvantages of acetate dialysis. So the main advantage of the acetate dialysis is that there will be a less chance of getting contamination for the dialysis. It can be stored comparatively long duration of time without getting contamination of the dialysis. And the delivery system. In bicarbonate dialysis, we use 2 concentrate, that is part A and part B, just to mix inside the machine and in an equal rate, that is appropriate ratio, and it has to come to the dialyzer. But in this, only acetate concentrate A, only 1 km, and it mixed with water and comes directly into the dialyzer for doing dialysis. This kind of simple dialysis delivery system becomes very cheaper. And disadvantages. The main disadvantage of the acetate concentrate is the cardiovascular instability, and in some patients we can see in absence of anemia or fluid overload, patients still have breathing difficulty. That could be because of metabolic acidosis. That can be treated only when bicarbonate level is more. What happens if we treat with acetate dialysis? That the acetate will go into the liver and get converted into the bicarbonate, and then it will be available for the systemic circulation. So it will be helpful if we use bicarbonate dialysis rather than using acetate dialysis. And the post-dialysis complications such as nausea, vomiting, post-dialysis fatigue will be more when we are using acetate concentrate. And another one important disadvantage of the acetate concentrate is the chance of developing amyloidosis. Amyloidosis is a deposition of a basic protein called amyloid, which is because of the beta-2 microglobulin. It's a protein, abnormal protein, which especially accumulate in the bones and causing pain and some kind of problems to the patients. Bicarbonate dialysis has an advantage that the patient will have a rapid correction of the acid balance. And bicarbonate loss. In acetate dialysis, there is no bicarbonate in the dialysis, so there will be a loss of bicarbonate during the dialysis. But in bicarb dialysis, there will not be any loss of bicarbonate because we have a 35 to 38 milliequivalents per liter of dialysis. Advantages, disadvantages now. As sterile, powder itself is not sterile, and the mixing procedure cannot be also be sterile. Most of us mix with some tubes in a bucket and all those things, and so the chance of getting contamination is more. And powder once mixed has a shelf life. Within 24 hours it should be used, or else the bicarbonate present in the dialysis gets decomposed, and it cannot, that decomposed bicarbonate cannot, dialysis with decomposed bicarbonate cannot correct the metabolic acidosis efficiently. Citrate dialysis, we can use the citrate dialysis for a patient who is having a problem with the heparin anticoagulation, who doesn't who are allergic to heparin or who may have no effect on heparin. Disadvantage: citrate binds the calcium in the blood, can cause hypocalcemia. Complication. This is what we are going to discuss mainly in this topic. Complication: the patient may go for hypotension. This is one of the major complications we face in almost 20% of the dialysis sessions. It is becoming complicated for us to treat the hypotension, especially because patient does not control their fluid intake, as well as because of some other patient-induced complications, patient-induced causes as well. So other complications which we are going to discuss about is muscle cramps, headache, nausea, vomiting, which can be controlled by profiling. Possible complications preventable modeling. Hypotension, muscle cramps, and headache, nausea, vomiting, all those things are almost related to the fluid overload, which we are removing during ultrafiltration, causing this kind of complication. And intradialytic, post-dialytic hypertension, as well as interdialytic hypertension, we are going to discuss about. Why we have to use profiles? Without using profiles also we can do dialysis. It is going to help us in minimally, but we may not achieve too much of effect by using the profiles, but we will be able to at least reduce the severity of the hypotension or severity of the muscle cramps, or even we may sometimes we may be able to avoid the complication by using the profiles. Methods how we can prevent complications related to the excessive ultrafiltration. Isolated ultrafiltration. We are going to discuss about isolated ultrafiltration, external derivation, that is the slow continuous ultrafiltration, and ultrafiltration sodium profiling. First we are going to discuss about the normal standard hemodialysis water level. Actually in standard hemodialysis intracellular compartment, we have three compartments in our body, that is intracellular, extracellular, and the interstitial fluid, that is the in between the cells. When you are doing dialysis, extracellular water will be removed, that is only from the blood water will be removed. The water, in the during dialysis, water is removed. Along with that, in normal dialysis, excess of urea and all those waste products also getting removed. So that time the osmolality of the fluid will fall, will decrease, causing the water from the extracellular compartment to shift into the intracellular compartment, as the osmolality stays high still in the cellular compartment due to the osmosis. So in movement of in isolated ultrafiltration, how the water movement is that in first hour, that is in we are doing 4-hour dialysis, means we will be doing first hour isolated ultrafiltration, and next 3 hours we will be doing normal dialysis. So during the first hour of dialysis, what will happen is that there will not be any, of course still the movement of particles will be there, urea clearance will be there, that is by convection will be there, but water movement will be more, and there will not be much clearance, maintaining the osmolality level in normal, so as to shift the intracellular compartment to the extracellular compartment and removing the fluid. Extend the time. By increasing the time, we can decrease the ultrafiltration rate, and so as to compensate the volume removed by during the dialysis, and allow the fluid from the intracellular compartment to extracellular compartment move as usual as it moves. Profiling and modeling. A machine controlled conductivity change is called as sodium profiling. Machine controlled ultrafiltration rate is called ultrafiltration profiling. Types of ultrafiltration and sodium modeling. We have 6 types, and more than these types are also available, but these are the most followed types of sodium and ultrafiltration modeling. Standard linear decreasing, increasing, step down, alternating, and step down alternating mixed. Standard linear. This is what we do usually, and linear decreasing. In the beginning of the dialysis session, more water will be removed, and more sodium will be given. we have to give more sodium in beginning of the dialysis is just to keep the osmolality of the blood compartment to be equal as it is before. Because when we are doing normal dialysis, the urea and all the waste products are removed and the osmolality decreases. If we are giving sodium, the osmolality can be maintained up to an extent. By using this principle, in decreasing profile, we can avoid much of the complications. Increasing profile. This is not much used widely just because of that patient may go with the sodium overload at the end of the dialysis. Because of that, we are not really useful much. This is believed by some people that at the end of the dialysis, patient is going for hypertension. So that time if we give more sodium, so the intracellular compartment fluid can shift into the extracellular compartment. Step-down profiles also almost same like linear decreasing profiles. Alternating. Alternating profiles have been used since 1990s when even the volumetric controls are not available. So what they have been doing is that first few minutes, that is first 25 minutes, they will be a very high ultrafiltration rate, and they will give a gap that is zero ultrafiltration, so as to give the time for the intracellular compartment fluid to shift into the extracellular compartment. Again, the water removal will be started after 25 minutes or 30 minutes, allowing all the extracellular compartment which is shifted from the intracellular compartment to be removed every cycle. And step down and alternating profiles are a mixture of the, we have discussed about step-down profile and the alternating profile. It is a mixture of both of the profiles. Machine with sodium and ultrafiltration profiling facility. Most of the machines now coming are with the sodium and ultrafiltration profiling. So here we have the Baxter 1550 model and the Baxter 550, Hope 73 and the Fresenius 4008 PES and 2008 DE, Gamro 896 and the hospital monitor machines with the sodium and ultrafiltration profiling facility. In Fresenius, this is the nowadays most of the machines which is purchased in most of the hospitals are this 4008S machines, which is having a ultrafiltration profile which is more advanced. So these are the combinations that green mark are recommended by the Fresenius Medical Care to give a sodium and ultrafiltration profiling. And apart from that, we can have our own choice by using the possible combinations given by them. Principle. This is ultrafiltration profiling just works by, because most of the water accumulating in the body gets accumulated in the interstitial and the intracellular compartment. This ultrafiltration profiling helps us to maintain the patient's volume, vascular compartment volume, that is preventing the hypovolemia during the dialysis session, just by allowing the vascular compartment to be filled with water which is from the intercellular and intravascular, that is interstitial compartment, to transfer it to the intravascular compartment. To fix the U of profiling, we may have to fix the goal first and the time, and then we have to fix the ultrafiltration, which kind of profile we want to keep. That is 1 to 6 profiles we may keep, 0 to 6 profiles we can keep, and other things we don't have to fix. And for fixing the sodium profile, we may have to fix the ultrafiltration, all the ultrafiltration values, time, and how much amount of volume we have to remove. All those things we have to fix first. And then dilution, we don't have to change anything. Gas sodium, we should never change. And crystal sodium, we may have to give at the end of the dialysis how much sodium we want the patient to go with. We have to fix that in the crystal sodium. And after that, we may have to fix profile, any profile, which kind of profile we want to keep. And last is the starting sodium, how much we want to give in the beginning of the dialysis session. That will be, the prescribed sodium could be 132 to 138, and the sodium starting English can be 145 to 155, 150. And thanks to everyone for giving me a chance. And I took the reference from Dr. Jagarajan.